Hello everyone, my name is Miss Guiney and I have now worked in the UK on labour ward for the last 6 years. Today in this video I would like to show you and take you around labour ward to show you what do doctors do on labour ward. As you all know, in the UK midwives are employed to help with deliveries. So what is the exact role of doctors? I'm also making this video to help my trainee colleagues who are either rotating into an obs and gynae placement, so you could be a GP trainee or a foundation year doctor, or you could be an SD1 budding obstetrician waiting to start in August. And if that fits any of you, or you're just somebody who's interested to know the role of doctors on labour ward, then do stick around. Also, for the expectant mothers out there, I'm making this video to talk to you about some of the specifics of the procedures we carry out on labour ward, just so you can get more of an idea, just in case you needed any of this done for you on labour ward. Okay, so in the morning, doctors start about 8 o'clock in the morning. Now, that's generally true for most of the university hospitals, but in other areas that I've worked in the country, they also start about half 8 or 9 a.m. But generally, 8 o'clock in the morning, the doctors have a handover. So, this is where the night shift handover to the morning team to inform them of the patients that are present on labour ward and antenatal ward, and inform them of the most high risk patients, so the morning team could be alerted as to who would need to be seen and prioritised first. This team, the night team, normally includes a registrar on call overnight, and a SHO. Now this term is going out of fashion, but it generally is equal to a foundation year 2 doctor, or a GP trainee, or an SD1 and 2 in obstetrics and gynecology. And the morning team generally would include a consultant on call, a registrar, along with again a junior who would include again either a GP trainee or a foundation year 2 doctor, or an SD1 or SD2 doctor. But basically it's just informing the morning team of what they can expect from the day, based on what is happening on labour ward. It's also a chance to inform the morning team of any planned elective work or any work that has been pending from the night before, in terms of any planned cesarean sections. Um, so after that, after the morning handover, we would start the ward round. Now this would include the consultant obstetrician along with the registrar, along with the senior house officer, um, and the labour ward coordinator, with inclusion of the anaesthetic colleagues going round labour ward, door to door, and basically finding out in detail about each of the patient on labour ward, discussing in depth about the patient, so the age of the patient, the number of deliveries the patient's had, the number of weeks the patient's pregnant, how did she labour, was she induced, what the medical problems she's got, is there any problems with the baby at all, is there any problems with baby's heartbeat. So all of this is discussed in detail. The midwife looking after the patient would inform the doctors on the ward round about all of this, and if there's any other information the doctors need to make any specific plans, then the doctors would generally go into the room, introduce themselves to the patient, and discuss the plan forward. This also gives the patient a chance to get to know their doctors and their team for the day, as it's very likely that in an emergency, the doctors will be called to, and will need attending. It's also a chance for the patient to meet the anesthetic colleagues and discuss things like epidural, if that's what they wish, and or if they weren't satisfied with the epidural, then that gives them a chance to discuss this with the anesthetic team a bit more in detail. Now, if you're a patient listening to this and you had a similar ward round experience, then please do comment below and let me know of what you thought about it. If you are fully dilated, patient is fully dilated, and there was any trouble in baby's heartbeat, that meant that we needed to speed up the delivery, then something called an instrumental delivery can be carried out in the room. Now, before any doctor would carry out or make a decision whether an instrumental delivery can be done or not, they will need to assess several factors, like the first thing being how low is the baby's head, what position is the baby looking in, how well is the mum pushing, how comfortable is the mother, because no doctor would want to do anything that would actually cause more distress to the patient in any way. So after assessing several factors, the doctor would then decide to carry out an instrumental delivery. Now, there's two types of instrumental deliveries, either a forceps delivery or Ventouse delivery. Now, I'm going to talk about the forceps delivery first and then go on to the Ventouse, which is the little cup on baby's head. Now, the forceps is generally defined as metal spoons that go around baby's head, and generally the idea is as the mum pushes, the obstetrician would pull and help deliver the baby. Now, because it's an instrument that's made of metal, it does leave marks on the baby's head and face. They generally tend to be pressure marks that go away with time after the baby is born. Um, to carry out this procedure, there's several things the doctor will need to set up and get ready with. So obviously, after attaining patient's consent, the doctor will need to get prepared for the procedure, which includes scrubbing up, which just means that they wash their hands and put a gown on, and as most doctors at the moment are wearing masks anyway, and then it would mean setting up a trolley similar to the one that you can see in the picture, obviously without the fan. So, as you can see, there's several instruments on the trolley, and which include cord clamps. Most instrumental deliveries mean also giving a cut called episiotomy down in the vagina. This just helps make more space to allow the baby's head to deliver along with the instrument without causing a tear, especially into the back passage called a third-degree tear. So this procedure can be carried out as soon as basically the trolley is ready, and if the forceps go on and lock properly, then the procedure would be safe to do so. As I said, there's several factors as to what will help the doctor to decide what to do best. So individually, I would not be able to comment on what's best for your baby. However, it all varies and depends on the day of the procedure. Now, this procedure would generally be carried out by the registrar or the consultant on labour ward with the assistance of the junior who might be present on labour wards, or if they're not present, then the registrar would do it with the assistance of the midwife. Okay, now we go on to the Ventouse delivery. Now this is a little cup that goes on baby's head. Now there's several of these cups. So there's either the silicone cup or something called the kiwi. As you can see in the picture, it's a plastic soft cup that goes on baby's head, and it creates a suction and just helps the doctor pull as the patient is pushing to allow deliver baby's head. Now this kind of an instrument leaves more of a little suction mark from where the cup is applied, usually at the back of the head, and again that kind of suction mark is also something that would go down in the next few days to weeks. And I'm not talking about the complications of these instruments. I'm just talking about simple, straightforward application of these instruments. Now, again, an instrument like this would sometimes mean, again, creating more space in the vagina. So again, making that cut, which is called the episiotomy, just to make more room to help deliver baby. Again, which instrument is used is based on the obstetrician's choice, which there's several factors that play into it, and the idea of using any instrument is safe delivery of the baby, and keeping the mother safe. Okay, so one of the big things that doctors carry out on labor ward are cesarean sections, and these can be planned cesarean sections or emergency cesarean sections. Now, based on different and various different reasons of why a cesarean section needs to be carried out, it could be something as simple as maternal choice, where a mum has decided that she would like a cesarean section, to anything more complicated like 4 previous cesarean sections and so forth. So whatever the reason is, a cesarean section is always carried out by doctors on labour wards. It'll either be the registrar or the consultant carrying out the labour ward with the senior house officer assisting them to be able to do the procedure, obviously after the patient has been anaesthetized. And it's usually a spinal anesthetic that goes in the patient's back that numbs them from the breast downwards. Very occasionally, a patient may be needed to put to sleep for this procedure, but the general idea is keeping the patient comfortable, and ideally awake so you can meet your baby and don't miss the first few moments of your baby's birth. Um, a patient's partner, that could be their mother, their friend, their husband. So whoever's their birth partner could also come into theatre to be with the patient if she's had a spinal anaesthetic, as this means that they can share the first few moments together. A cesarean section generally is a procedure that can take up to an hour, obviously based on the complexity. So it might take longer if it's a complicated procedure for whatever reason. There's extra bleeding, or there is something different about the anatomy. As I said, for example, in ladies who've had previous cesarean sections, the tissues can get quite sticky, which means that it takes longer for the doctors to access the area inside the abdomen that needs to be accessed to safely deliver the baby. But generally, overall, it's quite a safe procedure to be carried out, and the decision for this is something that would again be taken, keeping in mind so many factors about the mum, the baby, the progress of labour, and so forth, and also obviously keeping the patient's choice in mind. Um, there is one very important thing that I would like to emphasize here, and that is patient choice. So, if you are a patient who would like to have a cesarean section for whatever reason, then please do speak to your obstetrician about this, because it is at the end of the day your delivery and your choice as to how you would like to deliver your baby, but this needs to be done in a safe manner. Now, for some patients, they will have a vaginal delivery. Now, that might be a normal vaginal delivery or a forceps delivery, or a Ventouse delivery. However, the placenta may get stuck, which means the placenta is not delivering on its own. So, usually, what tends to happen is after the delivery of the baby, you're given a medication that helps the uterus to contract, and which enables the placenta to come away. Now, for some patients, that doesn't happen. It could be because of any previous operations, surgeries that you've had inside the womb that again create the sticky tissue and things get stuck. But sometimes it's unexplained and we can't really say why it's happened. But it means that the placenta is stuck and it will need delivering, which generally means taking the patient round to theatre and again using one of the anesthetics, like either a general anesthetic and putting the patient to sleep, or a spinal anesthetic where we do an injection in the back of the patient, again, which numbs them from breast downwards and allows the placenta to be slowly teased away from inside of the uterus. Now that's again a procedure that's carried out by the doctors on labour ward. This also enables, once a patient is under anaesthetic, allows us to carry out a thorough assessment of the vagina in case of any tears and repair them at the same time. Okay, so vaginal deliveries can mean tears in the vagina. Okay, so, and they are very, very, very common. The good news is most of these tears can be repaired in the delivery room itself under local anesthetic and with some gas and air. However, there is a specific kind of tear called a third-degree tear, which means it's a tear into the back passage, and that involves the muscles and the tissue of the back passage, or a fourth-degree tear, which has completely gone through the rectum. Now, if such a tear happens, it's best repaired in theatre under sterile environment, and also it means that it can be done well with extra lighting and with the comfort of the patient. Because what you don't want to do is start repairing such a tear in the room and the patient moves, for example, and you end up not stitching it right. Um, so this kind of a tear would also be repaired by the doctor on labour ward, ideally a consultant or registrar, and they would advise you to be taken to theatre and consent you for theatre and take you around. Such a repair, the repair itself would take about 15 to 20 minutes, depending on how complicated it is, but the whole thing might take up to an hour. Um, factoring in getting the anesthetic on board and so forth. Okay, so apart from carrying out all the complex procedures I've talked about that doctors do on labour ward, doctors on labour ward also help to train the juniors on labour ward. So it could be a consultant training the registrar, or the registrar training the junior member of the team, and just showing them around and helping them carry out complex tasks on labour ward, because as you can appreciate, this specialty has a lot of practical procedures, and only by watching and doing them is the best way to train and learn. And there is always a huge demand on new and junior members of team as more and more senior people either retire or leave the specialty for one reason or the other. So apart from carrying out all the complex procedures, doctors on labour ward help train their colleagues, so we can keep the staffing numbers that are required and help these junior doctors get to where they need to get to in their careers as well. Okay, now doctors on labour ward also carry out difficult artificial rupture of membranes. Now, you may or may not know that there is membranes around baby's head. So once the cervix starts to dilate, and if you had to perform a vaginal examination on a patient, you can actually feel the membranes on the baby's head and not the head directly. It's only by breaking these membranes you can start feeling the baby's head. And this also allows the baby's head to press against the cervix better so that it dilates, hopefully quicker, and your labor progresses quicker. So this kind of procedure might become important if, for example, we can't monitor baby's heartbeat through the abdomen and we need to put a little clip on baby's head which helps to pick up the heartbeat, or it might mean that the lady's progress in labor is slower, and we would like to speed up things by breaking up the waters because it allows the better application of the head onto the cervix, and it's by pushing of the baby's head onto the cervix with the contractions that allows the cervix to dilate. So it might be for various different reasons, and the doctors would be the ones who'd carry out this procedure on labor ward. And we usually do this with something called the amnio hook, which is a little plastic instrument with a tiny little hook on its end, which hooks onto the membranes and breaks the waters. This allows free flow of the waters around baby's head, and helps the labor in one way or the other. Okay, so this is a very common one. If now, depending on how senior the midwife is, more senior midwives can do cannulation on labour ward. Now, if there is, however, any difficulty for the midwife to carry out the cannulation, which means putting a little plastic tube into the veins of the patient, then that's something that the doctor may be called for as well. It might be the obstetricians or it might be the anaesthetic doctors, but it'll be the doctors who'll be called to help in this situation as well, as they are more trained to deal with difficult cannulation of the veins in these situations. Okay, so one of the other tasks the doctors might do is managing postpartum hemorrhage. This is bleeding after a patient has delivered. So it could be when the placenta is still inside and has not delivered yet, or the placenta has also delivered, but there is a big bleed after it. Now, for those of you watching or are expecting to deliver, I do want to inform you that there will be some bleeding at the time of your delivery, and that is completely normal. This bleeding I'm talking about, which is more than average, which happens in some patients and needs further assistance by the doctor. So it could be because of the tears that the patients incurred during the vaginal delivery, or it could be because the placenta hasn't separated, or the tone of the uterus, because the uterus is a muscle and it needs good tone to be able to contract well. And if it doesn't contract well, it can bleed. And there could be several reasons of why there is bleeding. I'm not going to go into the details of it all here, but this is one of the things. If there is an extra amount of bleeding, your midwife may pull the emergency buzzer to inform the doctors, which would include the labour ward coordinator as well, and the anaesthetic team, to be alerted and to come and assess the lady in the room to see if the patient needs to be taken to theatre, or whether it's just giving them some extra medications that will stop the bleeding. Okay, so in between all this, doctors will try to get a break, to get some refreshments, at least be hydrated, which I must say, as among us doctors, then they're not very good at looking after themselves, because they tend to get so busy with looking after everybody else, especially on a working day. And my advice to the juniors listening out there would be that please look after yourselves, because if you don't do so, nobody else will do it for you. So keeping well hydrated, getting some lunch through the day is absolutely essential, and caffeine keeps you going. And lots of hospitals around the country have got this system of having a tea trolley, for example, where or the staff would prepare the trolley and bring you around, so the team can have a cup of tea slash coffee whilst they are carrying out a task, for example, say on the computer, as a lot of paperwork these days is actually done on the computer. Um, it also gives you a chance to reflect about what you've just done, and gives you a chance to unwind whilst you're having your sip of tea, because labour ward is a fast paced environment, and it's very important to be able to move on from one thing to another, and you can only do so if you have moved on from one task to the other. And one of the ways that you can do so is by making sure that you are um, being well hydrated. And if you do get a chance to have a cup of tea, then please do sit down and do so, because that will really help you to get on your feet again and carry out the tasks you do need to do. So this is the end of the video, and if you found this useful, then please do give it a like and a thumbs up, and comment and subscribe to my channel, and let me know if there is any more videos of working as an obstetrician and gynecologist, or there's anything that you would like to know about pregnancy and antenatal care.